Next, I'll invite Dr. Don Morris to come join us up here. Anybody attempting to improve clinical outcome or affordability intuitively knows that if one could do a better job of anticipating when the nature of future health trajectories and health spending trajectories and when might be the most opportune ambush points to intervene would be an enormous advantage. And one of I think Stanford's most illustrious graduates, David Eddy, decided to take a serious run at this. I think 35 years ago. And 35 years later, actually sooner than that, but at this point, 35 years of maturation later, Archimedes is a tool that takes advantage of all the RCTs and outcome studies that are published that are considered credible, and knits them together to essentially develop what I refer to as a cognitive appliance for clinicians and potentially for patients as well. So, Don, thanks for joining us.
Great. Well, thank you very much for that nice introduction and for the mentions of Archimedes you've heard before. Just for those of you who aren't familiar with Archimedes, we're a healthcare modeling company that actually started as a research project, as you heard, within Kaiser Permanente by a gentleman by the name of Dr. Eddy, and that was in the 1990s. Now we're sort of an independent company in San Francisco, and we work with a lot of the organizations here. And essentially we're a bunch of mathematicians, and we're using math and modeling to try to figure out how to most efficiently move the healthcare needle and answer questions that people have for us. So we do a number of different things. Anthony, I think, touched on some of them. What I'd like to talk about today is some work that we've been doing with organizations like Kaiser and Intermountain Health on how to improve prevention. And I'm just going to, maybe I'll just kind of skip through this. Essentially, these are organizations who do a really, really good job of prevention right now. They have great HEDIS measures, as you've seen. And the challenge that they're finding is that to move the needle further requires more and more work and more cost. And they want to find ways to continue to improve prevention and do it in a cost-effective manner and find new ways to approach that. So we have a product called Indigo, but I'm not really going to talk to that. What I want to talk to today is sort of the general principles that we've found and what our learnings are from working with these organizations. I think you've seen lots of graphs like this. Just in the interest of time, I won't go much into it, but you can see we're capturing more and more of the risk, so we're moving in the right direction, but as you've heard, there's a lot of frustration about why can't we move faster. And so just to give you sort of the highlights of what I'll talk about, I think the things that we think are key are prioritization, engagement, and capturing people who fall through the cracks in various ways. So actually to sort of, I think that we've reached a point in the medical community where guidelines are so ingrained in us, the ones that we work with in cardiovascular disease every day, that we sort of think of the guidelines as a surrogate for outcomes, improve our HEDIS measures and the outcomes. And certainly guidelines have taken us on a huge journey to improving care over the years. It's been revolutionary. But they're not exactly the same. And I think to understand that, we should go back maybe 30 years to when David Eddy and other people involved in the beginnings of evidence-based guidelines were coming up with guidelines. And their challenge then was to bring evidence into medicine in many cases where evidence really was not being used in medical decisions. And their challenge was to do that in a world where people didn't have computers and they didn't have electronic medical records, and to come up with guidelines that people would follow and use and remember, and that would improve patient care. And they did that, and they did that very well, and it's had a huge impact. But as we push the needle further, we have to start to ask, Are there things that we can do now with the technologies that we have now that would enable us to go beyond what we've been doing or to approach it in new ways? So at the risk of sacrilege, because these guidelines are wonderful and they're great and certainly have revolutionized care, I just want to go through some things that they don't do. And if you go to Diabetic and talk to him, if you go to the NCQA and talk to them, they will say, yes, we had to make the guidelines the way we did, but they don't do these things. They don't prioritize people. They don't prioritize different interventions. They don't tell us where we should start and where we should finish. If we have a patient with 12 gaps, what's the most important one? They don't really take patient preference into account. Or they don't make it easy to interact with the patient about what that patient should do. They don't really engage them in their care. And they miss certain people because perhaps they fail to have a certain measurement and they're not getting diagnosed. So, we have a new world now. We have electronic medical records. We have better risk models than we had. We have computers in the exam room. And so what we tried to do is take a different approach and think about this from the perspective of, so I guess what I should say is that the guidelines that we have are these, it's a set of rules that are basically the thresholds on particular risk factors. And that's the simplicity and the beauty of it. But in a computer age, maybe we can think about things a little differently. So what we did was, we said, what if we take all the information in the electronic medical record for a patient and we calculate their risks. We calculate the risk of an MI, of a stroke, of kidney disease, of diabetes complications and different cancers, depression. And then we have a panel of preventive interventions, and we create models for the individual impact that those interventions are going to have on each patient. And so we can make a personalized calculation for that patient of, well, how much impact is this going to have on their mortality, on their morbidity, on their quality of life over the next 5-10 years. And we can generate all those numbers, and we can take hundreds of thousands of patients, we can run them overnight, and we can, for every single patient, calculate what's that impact on their health of each of these interventions that they're not doing. And so what would you do with that information? Well, one thing you can do is prioritize. So I think what's happening is that as we strive to do better at prevention, we're engaging other ways of reaching patients and improving prevention that are more expensive, they are more resource intensive. Coaching, outreach, making phone calls, sending people for home visits. These are having classes for patients. These are expensive things. We'd like to do them for everybody, but the truth of the matter is we have to keep the economy in the viability of this economically in account. And so we can't necessarily apply all those interventions to everybody who has a gap for blood pressure control or for statin control. What this graph shows is that, and this is just taken from N. Haynes, but we ran those people through our tool, and the people who are indicated for statin under ATP3, we just calculated what's the delta in their absolute risk of a CVD event in the next 5 years that they would get from taking that statin in percent. And so all these people qualify for statin, and however, if we rank these people according to that delta, and you see on the left, people whose risk would be reduced by over 10% in the next 5 years. And on the right, you see people whose risk would be reduced very, very little. And if we're going to employ these more expensive programs for reducing risk, we need to prioritize who we apply them to make them cost effective. And you see that there's this really huge difference between the people who would benefit the most and the people who would benefit the least. The green line, by the way, is if we sorted those people by their LDL, and it's how much, and you see it, there's a little uptick on the left-hand side for people with high LDL, but it's really not that correlated. And I think the point here is that, you know, we're in the computer age. We can look at more than one biomarker. We can look at more than two. We can take 100, 130. We can take all that information, and that's going to give us a better prioritization, and it's going to give us more opportunity to do things that we want to do with these patients and justify them economically. And so that's sort of the first point that I wanted to make. And you can see if you translate this into dollars, you know, how much does that MI or stroke cost you? There are people here that getting them that statin will save you $1,000 a year. So that justifies quite a bit of action. So the second point I want to make is about engagement and communicating with patients. So part of our tool, you see it's called Indigo there, is this interface that providers, physicians can use with patients, and it's for a personalized calculation of their cardiovascular risk. And you might have a conversation that would go something like this. It would say, you know, that, you know, Mr. Atwood, your risk of an MI or stroke is really higher than it should be. And I want to talk to you about it. We have this program. We can calculate your personal risk based on your information. And what it really should be for your age is that green bar on the left. And what it is, if you're taking that diabetic that I prescribed you last year, it's that black bar, the third one. But if you're not taking your diabetic, it's the red bar. So first, that's why it's important that you take your medication every day. But the second thing is, either way, it's higher than it should be. It's a lot higher than it should be for your age. And the good news, though, is that there are a lot of options for how you can reduce it. And those are all shown in the gray bars out on the right. And each of those gray bars is what your risk would be if you did that one intervention, what it would go down to. And this is an interactive thing, so you can check on the different boxes, and then as that blue bar goes down, it shows you what your risk would do if you did any combination of those things. That can be printed out, it can be given to the patient. And in our pilot that we did in Kaiser, Hawaii, we had, I think the most striking finding was that the patients who had gaps for statins, and Kaiser does a very good job of closing the gaps. So the patients who have gaps probably have been approached before multiple times about it. In the control groups, only 8% of those actually went and picked up the medication within the next 10 days. But when they saw Indigo, it was 43%. So I think the point here is that quantitative communication and personalized communication can be really valuable to some substantial subset of the patients. Maybe not every patient, but there are some who this is very meaningful to. The third point is that there are patients who fall through the cracks because, for example, they don't have a lipid measurement. You know, they're not going to be diagnosed, and you might have a program to, okay, you know, everybody over the age of 40 who doesn't have an LDL, let's call them up and ask them to get an LDL. Our risk algorithms were made so that they're very flexible in terms of the amount of information they need. So whatever information is missing, we can still calculate risks, and we have confidence intervals around them. And they can be used to essentially prioritize everybody in these groups for going out and capturing them and bringing them into the system. How are we doing on time? Okay, thank you.